Okay. Okay. Hi everyone. Okay, so we are back and I see doctors there. Thanks for coming back, guys. Okay, so I'm just going to send Doc an invite. Sure, you guys will come back. Thanks, guys. We're talking about ovulation predictions. So we're going to talk to Dr. Skye de Jongh. Hey, Dr. de Jongh.
Oh, sorry.
Hey.
Hi, how's it going?
Good. There we go. There you are.
There we go. Sorry. Okay, let's do it.
There we go. Perfect. Perfect. Good. How are you doing?
I'm very well, thanks. How are you?
Good. Good. Thank you. Sorry, I think the last time you joined on the Vitalab handle.
Yes,
So that's
I've
why
since then forgotten how to join on it. So, yeah.
No
It's
worries.
fine.
No worries. So we're talking about ovulation prediction, but before we go there, if you could please introduce yourself, tell everyone who you are, what clinic you're from.
Perfect, will do. Well, good evening, everyone. Thanks so much for joining us. My name is Dr. Skye. I am one of the gynecologists working at Vitalab in KZN. We are situated in Umhlanga, and we do general gynecology as well as fertility treatment. We've been there for about 2 years. We're 3 doctors, Dr. Yorks Siku and Dr. Kobus Kutsia and myself.
Perfect. Okay, so today we're talking about ovulation prediction. And like I said, a lot of women don't actually know the importance of knowing when you ovulate and when you're fertile and your fertile window, everything about that. So that's what we're going to discuss today. And the first question is, what is ovulation?
So I think this is a really important topic, and I actually spend a lot of time in my consultations teaching people about just how their body works so that they can better understand why it is they're not falling pregnant, and sometimes just understanding how the cycle works can be the key to you falling pregnant. It could always be a time issue. So ovulation is the releasing of usually only one egg in a cycle. So what happens is you're born with a set number of eggs, and by the time you hit puberty, you're down to about 300,000 eggs, and every month you lose about 1,000 eggs. Okay, so these eggs are all kept in a tiny little storeroom in the center of your ovary, and they're released into tiny little follicles, which are like little bubbles. Those are the things that we look for on the sonar. So they're in these teeny weeny follicles, and they take about 5 months to journey to the outside of the ovary. In their final month, they become visible on the ultrasound, and your brain sends a message in the form of FSH, follicle stimulating hormone, to stimulate the follicle to ovulate. So it picks one follicle. So everybody has a different number of follicles available per month, and that depends on your age. So on average, let's say if you're 30 years old, then you probably will have about 6 to 8 follicles per side, per ovary. And so of those 16, let's say, follicles, one of them gets picked to be the dominant follicle. And so for the first half of your cycle, which is usually about 14 days, your FSH from your brain is telling your ovary to grow that follicle. And it starts off at about 6 millimeters, and then it grows to be about 18 to 20 millimeters. And at that point, a message coming from your brain in the form of something called LH tells it to ovulate. So everybody's cycle is different. So you may be someone who has very short periods that are 21 days, or you may be someone who has really long periods that are 35 days. Or you may be one of those people who has a 35-day period this month, then 30 days next month, and that can make it quite tricky to detect when your ovulation is going to be. And so what's quite helpful to understand is that the part that is set is the second part of the cycle. So from ovulation to your period is usually 14 days. The part in the beginning is the variable part. So the first part may be short or long, and that's what makes the cycle short or long. So the trick is figuring out when that ovulation is happening, and that's why you're on this talk, is to get those answers.
Yeah. So, what is the importance of ovulation?
So if you're not ovulating, then there's no egg available, no mature egg available for the sperm to meet and therefore to fertilize. So if you are not ovulating, then there's no egg available, so there's no baby. Okay.
Yeah.
And then on top of that, that dominant follicle that we were talking about, that with a mature egg in it, is responsible for secreting something called estrogen. And that thickens up the lining of the inside of the uterus. It's called the endometrium. And that prepares the uterus for a baby. And so without a dominant follicle, that process doesn't happen either. So you'll find that women who are not ovulating won't see their period. So generally, the rule of thumb is if you're seeing a regular period, probably you are ovulating. But if you're not, you may not be ovulating.
Okay. And what is the importance of ovulation? Oh, did I just ask the question? So sorry. How do I calculate ovulation and my fertile window?
So your fertile window is 5 days before ovulation and 1 to 2 days after ovulation. How do we calculate that? So sperm can live inside your uterus and therefore in your tubes and be available for ovulation for 5 days. The egg is only available for 24 to 36 hours after it is released. So if you have intercourse 5 days before ovulation, there is a chance that you may fertilize, or 2 days after. So anywhere in that period. So that's quite a short window, 7 days. And because many women will have up to 5 days variation from month to month, it's safer to have a larger window of fertility. So often if you use an app, they'll only give you 7 days. But if you tend to have, variation from month to month, it may be a better idea to make that window a little bit longer, closer to 10 days. So maybe 2 days on either side of those 7 days. So if you are expecting your ovulation around day 14 because last month you had a 28-day cycle, then you would have intercourse 5 days before that, but maybe even 7 days before that. So from day 7, every second day, up until maybe, let's say, 4 days after that to 18. So it's quite a big window. So that's where some other ovulation detection techniques come in helpful. So by just using your app, you may miss it. There have been studies that have shown that just using the app and dates is not very effective. The next option is something called basal body temperature, or BBT. So it's quite a simple method. You need quite a sensitive thermometer that reads up to 2 decimal points because it's very subtle changes in your temperature that happen. The issue with this method is that elevation in temperature often occurs after ovulation. So that only leaves you with a 24 to 36 hour window. And if it happens, say, 6 hours after that your temperature goes up, you may have missed the point. So it's not a very sensitive method. The next method is using cervical mucus. So cervical mucus during the window of ovulation becomes a lot more watery. So when the sperm needs to get in through the cervix, that mucus becomes less thick and more watery, so that the sperm can more easily go through the cervix. So before ovulation, your cervical mucus will be quite thick and gelatinous and sort of opaque and a whitish color. And so everybody's discharge is different. Everyone's normal is different. But around ovulation, in those 24 to 36 hours, that mucus will become clear and it'll look like raw egg white and it'll be quite stringy. Okay, so that's quite a sensitive sign, and 87% of people can accurately detect their ovulation using that method as well. So using that in conjunction with your dates.
Yeah.
And then you can also feel inside the vagina. If you feel your cervix, and you just make a habit of feeling it every now and then so that you can see when there's a change. At within 6 hours of ovulation, the cervix actually opens up a little bit. It's called the pupil sign because it's like a pupil dilating, and your cervix, the hole in your cervix opens to 3 millimeters. So if you are feeling your cervix regularly, you may be able to feel the difference, but it's quite a subtle difference. Yeah. There are other ways that involve purchasing LH or ovulation test kits.
Yeah,
you can
I actually
purchase
sell
them online.
the pill kits. So I actually sell the pill kits that test your LH and FSH levels.
Yes.
Am I right?
So
Yeah.
yes, so LH is that hormone that we spoke about that triggers ovulation. So that's a great one to use. It is very sensitive. It can detect ovulation in up to 97% of cases. So it is very sensitive. However, it is not effective in women over the age of 40. So sometimes over the age of 40, your LH levels start to go up, and so it can give you a false positive reading. Also, if you have polycystic ovaries, your LH levels may be elevated already, and so it may give you a false positive reading. And yeah, those are the two main ones. Oh, and if you used a trigger. So if you're doing timed intercourse and you used an HCG trigger, we call it Ovitrol, then that alone will cause the LH to go up. So it's not going to confirm ovulation. It's just going to tell you the LH went up because you got a trigger. Okay, so it can't be used in those circumstances. So yes, the LH kits are very effective, but you need to use them for quite a few days. So often what happens is my patients say, oh, I've been using them and I never get a positive. But it's because they're using it at the wrong time, or they'll only do it for 2 days. And 2 days is quite a short window, and maybe your ovulation is just the next day. So you actually need to do it for about 4 days to see, where your ovulation really is. The FSH is not as sensitive as the LH because it peaks before the LH. But yeah, it is also a good test. There is another test available in Europe. I don't think it's available here, where they test salivary salt levels. So just before your ovulation, your estrogen level goes up, which causes another hormone from your brain called ACTH to go up, and that causes you to hold on to salt. And it causes what many women experience, some sort of bloating and sort of water retention. That's thanks to that.
Wow.
And this test, it's so interesting. You basically spit onto this little slide with a light underneath it, and it shows burning of that saliva, which is really interesting. But it's not as effective as the LH, and it's not available here. So that was just an interesting one.
Okay. Someone just
asked,
just asked, is it a specific time of the day one should test?
Yes, that's a great question. So ovulation typically happens between midnight and 8 a.m. With an average of 2 a.m. Of the majority. So first thing in the morning is the best time to test for your ovulation.
Okay, so we were talking now about the signs and the symptoms. Are there any signs and other symptoms that we detect to say that, okay, we could, besides the mucus, cervical mucus, are there anything else?
So some women are able to feel their ovulation. This is called Meckel-Schmerz syndrome, where you're actually able to feel, oh, there it went, it just popped, I ovulated on the right. The reason for that, we don't know why some women have it, and some women develop it after their first child, it's quite interesting. But we think that the bursting of that little bubble, that little follicle, and then the resultant follicular fluid that goes into your tummy, you just become more sensitive to that, and that's how you know you've ovulated. So besides the mucus and then the pupil dilatory sign, sometimes you can feel it, and then your temperature goes up by about 0.5%. 0.5 degrees the day after you ovulate.
Okay. And then what can I do if I'm not ovulating?
So it's important to figure out why you're not ovulating. Yeah. So I'd advise, if you're not seeing your period regularly and you're trying to conceive, don't even waste time. Don't waste time having intercourse for a year and then going to see a doctor. Come and see a fertility specialist before that point so that we can work you up and figure out why you're not ovulating. So the most common culprit is polycystic ovaries. So polycystic ovarian syndrome is a genetic condition where those hormones coming from your brain, the FSH and the LH, are just kind of out of whack, and they just don't chat to the ovary the way that they're supposed to, and so you don't get that dominant follicle ovulating every month. You just get a collection of these little immature follicles around the edge of the ovary, and so you don't ovulate, you don't get a building up of that lining, and therefore you don't have a period. So there are quite a few ways to treat polycystic ovaries. We can start off with Insumax, something like Insumax Q. There are a whole bunch. There's picositol. There are all sorts of different vitamins. I think you also sell some of those. And they basically the most important ingredients there are, obviously you need to have your folate, but then your inositol lowers your insulin levels. Your CoQ10 enzyme will help to improve egg quality, and then that, in conjunction with some weight loss, in conjunction with some metformin, can often get you to ovulate on your own. So just 50% of patients with polycystic ovaries, if they lose 15% of their weight, then they can start ovulating on their own and they don't need any treatment. But some of them, that's not enough, and they need ovulation induction. So that would be the next step, is we would then give a medication. Usually our first step is something called letrozole or Femara. And basically it works in a kind of backdoor way where we decrease your estrogen levels, and that sends a message to the brain to say, hey, there's not enough estrogen, can we please have more FSH? And then the brain sends more FSH to the ovaries, and then that causes your follicle to grow. So that's generally our first step for ovulation induction. And then if that doesn't work, because often these ovaries have been like ignoring your brain hormones for such a long time, they're like, no, they're not listening. So we end up then going to the next step, which would be injectable gonadotropins, and then we slowly increase those. But it's such a tricky, it's a bit of a tricky thing, because you don't want to give too much and cause all of those follicles to be stimulated like we do in IVF. We still want only 1 or 2 follicles, because we don't want to end up with multiple gestations and all the risks associated with that. So polycystic ovaries is generally the most common cause. We also have anovulation due to other causes though. Patients who are very, very skinny or very, very fit, their bodies recognize that actually it's not a great time for you to be pregnant, and so it just stops sending those FSH and LH hormones from the brain, and so your ovaries just don't get any signals at all, and so ovulation doesn't occur. So in those patients, it's important to manage the lifestyle issues, so cut down on the exercise a bit, increase your BMI a little bit. Ideally we want your BMI between 18 and 25. And then hopefully, just by making those lifestyle changes, we'll be able to kickstart your ovaries into doing what they're supposed to. But in some cases, they need a little bit of help as well. Yeah. And generally, those patients, we go straight for the injectables because using the backdoor route just doesn't work.
Yeah. I actually, before I go to the last question, I was contacted today by a lady somebody else put in contact with me, and just to get one of the doctor's details. And so background story of it is she's in a short period of time she's picked up about 30 kilos, and obviously she's got all the signs of PCOS. And but I said to her, go and see a fertility specialist and get the the correct diagnosis from him or her, and then to see what you can do, because she probably has PCOS. And she said to me that she's been to a gynae, and the gynae said to her, no, because I said to her, look, I've got PCOS and I'm on glucophage, and this is really, really helpful, because I was a size, I was under 60, I was about 60 kilos, and now probably doubled in weight because of PCOS. So, but the glucophage has helped me a lot. So go and see, a fertility specialist, because I was trying to conceive as well. And she said to me, her gynae said to her, oh no, glucophage is only for diabetics. Metformin is only for diabetics. So is there any point where a doctor can say, we're not going to mention names or anything like that, okay, no, you cannot, for PCOS, you cannot take glucophage or anything?
So you've actually brought up quite a contentious issue in the fertility world. Glucophage or metformin was initially thought to be this wonder drug. They thought, oh my gosh, it's so great. So the way it works is it sensitizes your cells to insulin. So instead of them being resistant to insulin and ignoring the glucose and keeping the glucose in your blood sugar and increasing your risk of diabetes, it says, welcome, welcome, come, we want all the insulin, we want all the glucose out of the bloodstream into the cells, and so it makes you lose weight and it decreases your sugar, and it's all great. And initially we thought it was really, really good at causing ovulation induction. We've since done lots of studies and found that actually it's not that great at causing ovulation induction, that weight loss alone is actually better. And that you should rather using letrozole to induce ovulation is actually more effective. So then metformin fell out of favor. And then they said, okay, actually, we should only be using it in patients who have an increased BMI and who have insulin resistance, because then it works as it should. But then there was another study done that showed, and this was quite recently, I think it was last year, that showed that there's a decreased miscarriage rate in patients with polycystic ovaries who are on metformin regardless of their BMI. So in my practice, I routinely put my polycystic ovarian syndrome patients on metformin or glucophage to decrease their miscarriage risk.
Awesome. Thank you so very much for that, answering that question. Okay, so our last question is, what can affect ovulation?
So our biggest culprits are the PCOS and weight gain, and then the opposites, weight loss, stress, eating disorders in particular. And then there are some patients who have never ovulated. So there'll be some patients who have genetic abnormalities or chromosomal abnormalities where they don't go through puberty. And those patients we usually pick up quite early because they don't have breast development, they don't have a normal hair development, and they have these teeny tiny uteruses, they never start their period. So those patients we usually can pick up quite easily. It's the patients who started off menstruating well and then suddenly stopped, or who were on the pill for 10 years and then suddenly stopped and decided, now I want to have kids, and their period's nowhere to be seen. So that can be an issue. Having said that, the pill, it does not cause that. There's lots of evidence to show that the contraceptive pill is super safe, and your return to fertility should be immediate once stopping it. So the contraceptive pill is actually the treatment for polycystic ovaries when you're not trying to conceive. So it's definitely not the baddie in this story. There are also medications that can interfere with your ovulation. So if you were using, so different contraceptives last for a different amount of time inside your body. So the ones that are really good to use prior to conception are things like the intrauterine device, whether that's the copper T or the Mirena, because as soon as you take them out, their effect stops. and then the contraceptive pill or the ring or the patch, because all of them, as soon as you stop using them, your fertility should go straight back to where it was.
Yeah.
The ones that are a problem in terms of return to fertility are, the biggest culprit is the 3-month injection, the Depo-Provera, because that one, although it is a very effective contraceptive, it can take up to 18 months for you to continue, to restart ovulating. And so, so that one is very tricky. And even if we give you injections and try and do IVF, your lining just does not build up if that Depo-Provera is still in your system. So that one is quite tricky to treat. The implant as well, that one hangs around in your bloodstream for quite a long time. The 2-month injection, not as bad as the 3-month injection, but it does also hang around. So those can definitely interfere. The other thing that can interfere is having a high prolactin. So prolactin is your milk hormone, and I'm sure that you've noticed that when people breastfeed, they don't see their period, and that's because their prolactin levels are high. So there are a couple of things that can cause high prolactin levels. The first thing and the most common thing is medication that people are on. So the antidepressant Esperide, that causes your prolactin to go up and can stop your period or cause you not to ovulate. A couple of antipsychotics, things like Dopacol, can interfere with your ovulation. And then some anticonvulsants can also interfere. And then other things that elevate your prolactin are if you have a prolactinoma. So it's quite a common tumor in the middle of your brain, right in the center in the pituitary gland. And I actually see it fairly often, and it's a benign tumor. It's pretty easy to treat. We give you some meds, it shrinks. In the minority of cases, patients need it operated on, but that can definitely cause high levels of prolactin and interfere with your ovulation. So if you do notice any milk coming out of your breasts, then that may be your problem. Also, after stopping breastfeeding, some people's prolactin takes a really long time to come down. They'll stop, and then there'll be milk in their breasts for 18 months. So some people do need a little bit of help to get going after they've had their last child. Other things that can interfere with ovulation are other medical disorders, things like hypothyroidism, so an underactive thyroid. Generally, we test all of our patients for thyroid disease at their first consultation, and we'd like their thyroid function, their thyroid stimulating hormone to be less than 4. If it's more than 4, then chances are it's having an impact on your ovulation. Vitamin D deficiency can also affect your ovulation, so we also test vitamin D routinely, and we make sure that it's more than 20, and if it's not, then we like to supplement. It's very, very common in the Indian community to have a very low vitamin D. Yeah, that's all I can think of right now.
That's a lot. That's quite a lot. Thank you very much. It has been very, very informative, Dr. De Jongh. Thank you for taking the time out also to do this talk again with us. It's been, like I said, very informative with ovulation being so important. And again, we are always trying to let women know why we do the talks is to try, when you have knowledge or when you're going into that doctor's surgery and you already have some form of knowledge about what you're dealing with, it actually makes things easier. You know what to ask the doctor, what to talk to doctors about, that type of thing. But we're always trying to educate women on infertility and that there is hope and there is something that we can do about it.
Definitely. I think the take-home message from this talk, if you are trying to conceive, is if your period is not regular, then don't bother waiting around. If it's not regular, just come and see somebody, because we need to figure it out. It's impossible for you to predict when you're going to be able to conceive. If it is regular, the easiest way to determine is keep an eye on the cervical mucus and just get those ovulation test kits. They're the bomb. They work really well. And I love it when my patients come in and they tell me, we've been trying for 2 years. The last 6 months I've had positive ovulation test kits. Then I know that's not the issue. We can move on to the next thing.
Yes.
And the opposite is true as well. I mean, if you've had 2 negative ovulation test kits, then you're wasting your time. Come in and I can help.
Yeah. And also, most importantly, to keep a calendar. You know, track your periods so that
Yeah.
you can, when you're coming into to the doctor, you can actually say exactly when your first ever period is, so they can work it out even better for you.
Definitely, and there's so many apps that can do it. I really like the Ovia app, Ovia Fertility. I find it very user friendly, and it's very clear, and it's quite educational. It gives you lots of info, lots of articles and things. So I generally recommend that one. But I mean, most of my patients come in with their app and pull it up. I ask them what day of their cycle they're on, and they're like, "Oh, let me just get my phone," you know. So yeah, I do find that people are pretty good at tracking it once they start trying.
So, if you can please just leave your details of how they can contact you if they need to contact you.
Of course, I'll do that. Thank you so much for having me, Leanne.
Okay, it's a pleasure. Have a great evening and thank you again. Bye.
Thank you. You too. Bye.